This video, we're going to be showing you the application of the Muenster cast. It's the monster of all casts. The idea of this cast is to allow range of motion in the elbow, almost full flexion and extension, while eliminating supination and pronation in the wrist.
There are a couple variations to this cast. Some of the Muenster cast actually leaves the full posterior portion in place, which does allow flexion but will eliminate any extension.
As you cut your stockinette for this cast, you're going to want to give yourself a few feet approximately. You're going to end up folding the stockinette back down over where you've casted, and it's going to cover everything. You can't give yourself enough extra stockinette on this cast.
We've had lots of discussions about this one, trying to figure out ways to perfect this cast. Again, the most important thing is you've got to realize that they will have that full flexion and extension.
You'll notice positioning the patient is just in slight extension beyond 90 degrees. When the patient flexes and goes into extension, it will make it so the wings on the cast won't impinge on anything.
You can see there in the antecubital fossa where we have that stockinette folded over there, you do not want to cut that out. If you cut that out, you're going to have fiberglass rubbing on the patient's skin and cause a sore. So make sure you leave that as is in the video, and then you'll be able to see how we pull that back.
It's important on this one as well to get a little extra padding on the elbow because they're going to be flexing and extending it. It makes it so the fiberglass won't rub on the skin and won't fold back.
Oftentimes this cast application is about 2 to 3 weeks out from a surgical fixation, either in the forearm or in the wrist itself.
Anytime you immobilize the elbow for longer than a few weeks, you run the risk of losing range of motion. It's harder to get your range of motion back in your elbow versus your wrist or fingers.
Yes, elbows will freeze up really fast. So as you can tell there, I measured both sides of the elbow, and we call these wings. So I measured the exact length that I needed to cut the splint material, and I'm going to make wings that are going to come out on the medial and the lateral side of that cast to inhibit that pronation and supination.
see how he's customizing these reinforcing strips. You kind of anatomically want to cut the grooves in them, make them so that they line up with the elbow well, so that there's no impingement through the range of motion.
Make sure you don't leave the proximal end cut off square. That's why I'm rounding it right here. You don't want any sharp points that would actually pinch or poke through your stockinette and give them those sores on their skin.
This cast, after a few times of putting it on, you'll find that it's not that hard of a cast to put on. It's tedious, and if you do your job, the patient will have a good experience, will get good results, and it makes you feel good about your job.
We are learning how to put on these casts the proper way for the patient so they can heal right. You do not want a patient to have an injury and end up with a stiff, frozen elbow.
Tape is the cast technician's best friend. You can help yourself by taping these reinforcing strips down. It makes it so much easier than trying to roll and hold them at the same time.
And then you can kind of eye the patient after you tape them on there and make sure they're not going to impinge with the flexion or extension.
When you handle the splint material without the cotton on it, that your hands will get a little sticky. It makes putting your gloves on a little bit harder too, but you'll notice Clint, every time he touches those, he'll do a fast rub with his hands trying to clear all that resin off.
That stuff will gum up your fingers, it'll gum up your scissors. Just enjoy the resin.
Cut through the web space here at the CMC joint. We're gonna do this first roll of cast material almost like you're doing a short arm cast. Go through there twice.
Sometimes you look at a cast like this and it can be kind of intimidating, but if you just picture yourself doing this in a two-step process that you normally would for a short arm and then carry it into a long arm, you'll get very comfortable with this.
Make sure the patient's neutral at the wrist and they are not extending or flexing it too much. Otherwise, that will make the cast much more difficult and could lead to being uncomfortable.
As you apply that first layer, you can still see how there's not a lot of fiberglass right there on the anterior aspect of that elbow in the antecubital fossa. That's going to be a good thing because that's right where we're going to cut with the cast saw to allow them to have the flexion. But you can see those reinforcers, those wings that we call them. You've got at least 7 layers of fiberglass from that splint material that's given the strength of the cast to inhibit the pronation and supination. Once again, that is why we're doing this.
If you place them correctly, when you go back to cut out your anterior and posterior placements on your cast, you will not cut through the fiberglass and it will make it much easier. Important to put a good mold on this cast. You want to eliminate any play in the elbow for supination and pronation, so you're going to put a good interosseous mold on the entire cast from the elbow distally.
Good interosseous mold really help to eliminate and slow down any supination and pronation that may occur if the muscle atrophies. We really want to eliminate motion here.
That's what I did there. You could tell with my index and middle finger I checked the lateral and medial epicondyle there of the humerus, go just barely proximal to that. Give it a good supracondylar mold there as well to help those wings snug up as tight as you can to the humerus. The other thing when you're molding, when you're doing that interosseous mold, make sure you straighten your fingers out all the way and use the palms of your hands. You do not want to use your fingers and cause finger marks or pressure sores is what they would get from the tips of your fingers molding.
Here you can see Clint pointing out, he can see the edges of the fiberglass, so this will make it a lot easier to align his cut.
So as you can see, I'm pushing on it right there, right on the wings. It's really, really hard. But right there on the posterior aspect and on the anterior aspect, it's soft where I've only got 2 or 3 layers of fiberglass, and that's right where I'm gonna cut. Make sure you have a Sharpie. This is where you get to put your artistic abilities to the test. See if you can draw an X. Make sure you cut out the right part of your cast. You don't wanna mess that up. I'm gonna outline the wings. That just gives you a landmark to follow using your cast saw.
Keep in mind on this particular Muenster cast, if your physician only wants flexion, you'll line it up just like he's doing here and only cut out the anterior portion, and that will still give your patient flexion and movement in the elbow. But this one, we're gonna go both sides. You'll find that this will allow almost full range of motion in the elbow and completely eliminate supination and pronation. Patients have a great experience with this cast. They always come back and said that it was wonderful.
You can see it's starting to form here. Right there on that anterior aspect, I actually came in a little bit. I've cut out numerous casts on the anterior aspect, and you go to do the flexion and it just pinches on them. So if anything, you can kind of cheat and go a little bit wider there so you don't have to come back and cut it a couple times.
Sometimes I'll go along the lines and score it on the slow speed, just so that when I go full speed, I can cut through it a little bit better without the cast saw jumping around.
Because there's lots of angles on this one. You're turning it. You're not just cutting straight like you usually do when you're cutting a cast off, but there's lots of angles and turns, and it's hard, especially right there on that anterior aspect there where you're doing both of those corners.
This is where, if you're not very careful, the blade can heat up and injure the patient or cause a burn across there. So make sure that that cast saw is moving and check the blade for heat periodically.
Also make sure you give that cast adequate time to harden up or start to cure, because if you jump in too quick, you're definitely going to burn them. They can heat up very, very fast.
After you've done this a few times, you'll learn how to hold that blade just right to make those turns. The very first time you do it, it's not very easy.
You'll get used to trying to switch between right and left hands. Otherwise, you have to stand on your head, kind of like I'm doing here. If you're always right-handed, you just have to figure out the right angle to keep the cast saw off of the patient, out of their nose, out of your nose. You just have to figure out the right angle to make it work.
Also, you can see how important it is to make sure that the first layer of casting is set up hard enough and you have a good proper mold down on the portion of your cast that will be utilized to stabilize this injury, because you will move the patient around quite a bit to get the perfect cut on these wings.
And if you don't put a good interosseous mold on your cast, when you go to fold back your stockinette, you don't want to be pulling your cast off. We have not experienced that, but if you don't put a mold on it, it definitely would happen.
You can tell on this medial aspect there, it was kind of hanging up on me a little bit. You just kind of have to keep working it, get your cast spreader in there in different angles. Sometimes it'll pop, sometimes it won't. If it doesn't pop, you have to go back and grab your cast saw and make sure you've cut all the way through the fiberglass. You can see right there on that medial aspect of the humerus, I haven't cut all the way out to the lines. Once I go here to flex it, you can tell that it impinges just a little bit, and I go back and cut that out.
This is the point where you check to see if you have to do any additional cuts to make sure there's no impingement and no irritation for the patient.
Sometimes it's better to cheat a little bit wider there. Your wings are already in place. They're going to inhibit that pronation and supination like we talked about. But he's just a little bit tight there. Once you go to flex him, you're going to start tearing and stretching that cast padding. That's going to be okay because we're going to cut it back and pill it over so it's just covering those wings. You can see that it's starting to stretch out there a little bit.
You can always use your patience. Ask them if there's any area where they feel like it's rubbing. You can easily eliminate it. In the stockinette and the padding, when they leave the office, it's going to feel kind of tight. But we always tell them the more they work on flexing and extending the elbow, the more that stockinette will loosen up and they'll be able to get more motion out of it.
this is definitely one type of cast that you want to be patient with yourself and make sure that you do everything technically correct before you send them out the door, or they'll be coming back.
Then you get to do it again.
Don't take it personal if someone comes back and they have an issue. That's where you learn. The next time you apply one of these, you can remember what you did wrong on the first one or something that you want to improve on. Cast technicians and clinics get that opportunity to make up for mistakes.
You got to realize here that, again, those wings are going to be passing by their biceps and triceps every time they're flexing and extending their arms. So make sure you have a nice, smooth, rounded proximal fiberglass. Also, you just use your cast saw and you have a bunch of little small pieces of fiberglass. Make sure you kind of pull all those out, because if any of those get caught underneath the padding, it's just going to cause a sore on them.
Once you're happy and you know that you don't have any rough edges on there, you go through and cut the padding right down the middle, and you'll end up folding it back, and the stockinette is going to hold it down in place. Here you're going to see why it's so important to have excess stockinette.
The main landmark to kind of check your stockinette is, like I say again, on that anterior aspect. I usually go about 3 finger widths down from that anacubital crease, and you can see that here. They pull it down all the way there. Make sure they don't have any of the cast padding in that anacubital fossa so they can have that full range of motion. So there you can see it's plenty long on that posterior aspect, but on that anterior aspect, that cut in your cast comes down a lot further. So I was just trimming the excess stockinette on that posterior aspect.
You can reach up inside and smooth out the padding that's underneath the stockinette before you put the finishing cast layer on.
Nice 2-inch stockinette on the thumb piece there. Allows you to double that up, fold it back, pull it down nice and tight. So kind of back at the base of that thumb to where your fiberglass can catch it when you come through to do your final wrap.
You can see the patient has full range of motion in the fingers and in the thumb.
This is a type of a rehabilitation cast, so you want to be able to make sure that the patient has good hand motion, no impingement on the fingers.
This is a post-surgical cast that we're treating, and at this point they could still have some swelling in their hands and fingers, so range of motion is extremely important.
just comes back to the basics here. All I'm doing is finishing it just like a short arm cast. I'm not going to put fiberglass all the way up the elbow. I'm not going to cover anything on that proximal aspect of it. I'm just going to go through the web space a couple times, make sure I catch my stockinette on the thumb piece, make sure you keep that nice white clean edge on the distal aspect, makes your cast look nice and pretty, and then you're just wrapping 50-50 all the way up and stop right there where you get to the fiberglass that's been cut out on the area where it's 2 to 3 fingers distal to that antecubital fossa.
Good point to bring out was if you were able to watch how well Clint rolled those edges back in the web space. Anytime you can do that, it makes for a really nice smooth finish, and then you don't have to go back and try to cut around it and get any of the imperfections out of that.
Don't fold the fiberglass through there. We've seen a lot of places where they'll, instead of cutting it through the web space, they fold it and it makes it twice as thick. So the thumb ends up rubbing on it.
On that proximal end, you can go up as close to that olecranon process as you can and then angle back on the anterior aspect to make sure they still have full range of motion. Cut off that factory edge on the lateral aspect of the hand. I've worn a cast, I've had lots of broken bones in my life, so that's where I actually figured this out, is if that piece starts folding back and you have some of those sharp edges, if you end it on the medial aspect, then anytime they're moving their arm, like when they're walking or running or anything, that fiberglass can catch on their clothes and rip your clothes. That's what it did to me, so I always end on the lateral aspect and rub it down good.
Taking this Muenster cast off can be a little bit different than your typical cast. You want to end proximally right where that wing comes down and meets in the antecubital fossa. So you can see how Clint's angling right there in that spot. That way you don't have to cut all the way up through your wing that has the fiberglass in it. And then same thing on this side, you're doing it just like a short arm, just like a regular cast, distally, and then as you work your way up, you'll notice that Clint's gonna do the same thing.
One thing I always like to do when I'm at the distal end or proximal end of a cast is I don't take the edge of the blade right to the skin. I'll start my cut about half an inch down and then work my way towards the skin so that the saw doesn't bounce out and hit the patient. Even though, like we say, you're not going to cut them, but it's a bad experience when you touch somebody with a saw blade. They just lose all their trust in you and they think that you cut them and you really didn't.
of times, especially with little kids, I would always take the cast saw and you just tell them it tickles. You can turn on the cast saw and just show them that it won't cut them. You can put it right on your finger. Just kind of gives them a little bit more confidence and trust in you.
And another thing is you warn them about the noise. Some of the cast saws with the vacuums on them, I just tell them it's comparable to your mom's vacuum in the house. It's going to be very noisy, and just know that it's just a vacuum, and then it kind of takes their attention away from the saw.
A lot of times when you're taking your scissors and cutting, you can look at my thumb right there. My thumb actually grabs the patient's skin, pulls the skin tight so your scissors are not going to cut them or bunch up.
Yep, you can push the skin down. You can also pull the stockinette up off the skin as you slide the scissors through there.
Use your thumb and pull their skin as tight as you can anytime you're putting scissors right on the skin.